So let me first start with Dr. Vivian Lee, who's the president of health platforms at Verily Life Sciences, where she oversees the development of digital platforms to support health system improvement and population health. Before joining Verily, Dr. Lee was Dean, Senior Vice President, and CEO of the University of Utah Health. She's also a widely published researcher in academic journals, and she is working on a book about solving the nation's healthcare crisis. Dr. Vivian Lee. Now let me welcome Dr. Vincent Nelson. He is Vice President of Medical Affairs in the Office of Clinical Affairs for the Blue Cross Blue Shield Association, which is a national federation of 36 independent Blue Cross and Blue Shield companies. He works in a variety of ways to ensure that BCBS incorporates clinical guidance for the best healthcare quality. Previously, Dr. Nelson held medical leadership positions at United Healthcare and was a professor at the University of Texas Health Science Center's Medical School in Houston. Welcome, Dr. Vincent Nelson. Now let me introduce Marvin O'Quinn, President and Chief Operating Officer of Common Spirit Health, the result of a merger between Dignity Health and Catholic Health Initiatives earlier this year. Common Spirit has a footprint in 21 states and is pledged to focus on population health, the social determinants of health, and more. As COO, Marvin is leading key aspects of the organization's transformation. He previously spent a decade with Dignity Health, most recently as Senior Executive Vice President and Chief Operating Officer. He was also President of Jackson Health Systems in Florida. Welcome, Marvin O'Quinn. Next, we have Dr. Rachel Warner of the University of Pennsylvania. She is Professor of Medicine at Penn's Perelman School of Medicine, a Professor of Healthcare Management at the Wharton School, and Executive Director of the university's Leonard Davis Institute of Health Economics. Dr. Warner's research focuses on how healthcare policy impacts care delivery. Her work has helped shape health policy in significant ways, and she examines such topics as a practicing clinician, economist, and medical researcher. As I said, it's not enough to have one job. You have to have 3 or 4 to be in this panel, except for me. I only have one job. Finally, let me welcome Seema Verma back to the stage. I said finally. I don't mean finally. Seema's not here. So it's here. Now let me introduce Dan Lillienquist, Senior Vice President, Chief Strategy Officer at Intermountain Healthcare. We mentioned Mark Harrison, who teed this up. Mark couldn't join us, but brought Dan in. So Dan is playing the role of Darth Vader today. We'll get to that. But before joining Intermountain in 2012, Dan served in the Utah State Senate, where he worked extensively on topics such as Medicaid reform. He's also the lead architect and board chair of Civica RX, the not-for-profit generic drug company and collaborative that we heard a great deal about from Martin Van Trest in our opening keynote. He's worked as a consultant at Bain & Company and was a founder of a strategy consulting company focusing on public sector pensions and benefit reform. Welcome, Dan. And Ben is back, and I'm back. So where do we start? We're going to start with Dan. The burden has been put on your shoulders to tee this up. We gave a little context, but tell us more deeply what your concerns are, what Intermountain's concerns are, and what are some of your thoughts about where what directions we might move in?
Well, thank you. Great to be here, and I apologize for Mark Harrison. Wish he could be here today with you. He's been ill, and he asked me to fill in for him. Let me just say, we hold you in high regard, the U.S. News and World Report, for the work that you do and the efforts you make to measure value. As we heard from Seema, the healthcare industry's got to change over time. It's too expensive. And as we look at how healthcare and value is measured, value unbounded by affordability ultimately is meaningless for people who are seeking to afford care. And I know that the data sets have been limited, But hopefully, as richer data sets become available, we can better track affordability as a component of value. If you think about the value equation, it's a function of price, quality, safety, affordability, in the sense that how much can people actually afford to pay, and not just price, because there are different people who have different thresholds of ability to pay. And it's a combination of all those things. And a partial derivation of that equation is very, very dangerous. If you focus just on a specific measure of quality or an outcome, that might lead us to make decisions as a healthcare industry that actually are suboptimal. For example, we know that today we can safely do joint replacements in an outpatient setting, in an ASC environment at a much lower cost. We know that with telemedicine, we can keep lower acuity services in rural hospitals instead of bringing them into tertiary and quaternary facilities. The measures, just measuring an overall outcome on a specific hospital basis, doesn't track systemness and the ability to actually meet people where they are with more affordable and actually more convenient options for care. In fact, the way the measurements today would incent hospitals to actually keep lower acuity services in their hospitals to make sure that their overall rate of infection or complications is lower. And that's a really tricky situation. One, it's not good for consumers down the road, and we've got to find a better way of measuring that. But that said, we are limited by the data sets we have available. Hopefully some of the new data sets that particularly at CMS and CMO talked about will help us begin to bound quality and safety, balancing it with cost.
So, Seema, we've all been here, but you go a little deeper in some of the data that you think is I guess, gettable. I mean, how do we get our hands around this? What do you want deeper down, and how cooperative are institutions in giving it to you?
Sure. I think first off, as we're moving towards value, the concept here is that we're listening to what patients want. And all of us have had the experience when you go into the doctor's office, you just don't know what you're getting. You don't know what it's going to cost. You don't necessarily have information on the quality of the physician. And so those are some of the things that we're trying to do, is transform the system, not only to make sure that patients are empowered with the information that they need to make decisions that are going to work best for them, and have them make those decisions, not the government. And then secondarily is moving the system to paying for care in a different way, paying for value. In terms of information, I think we're very committed to unleashing data. Our first priority, though, is privacy and security. You have to make sure that patients have those protections in place. But we want to make sure information's out there. That's why we focused on price transparency, as we just talked about. But even on the quality level as well, one of our goals is to provide more data out there. We want to revamp all of the data that we have on quality, make sure it's easier for folks to use. But we really appreciate the work that you all do, US News and World Report, and there's other folks out there that are trying to do more with quality. We see our role as enabling that competition, enabling that data. So, I mean, one of our goals this year is to put out more quality information, not only for patients, but putting it out in a format so that it can be used by the system holistically.
I just want to say to the other panelists, it is not a requirement that you say something nice about US News and World Report. This was unscripted. I very much appreciate it. And I mean, we do joke sometimes, but I think we do, with some sense of humility, feel that we do play a role in this. That we're able to convey information to consumers in a very digestible way, which is what we, our main job is still. We're not the experts about getting that data out. So let me talk to some of the experts here. Marvin, you're running a health system, not dissimilar in some ways, I guess, to Intermountain. Or tell us about where you fit in this picture and what you want to do going forward in terms of measuring value.
Well, we have become a very large organization, but prior to that, we were two organizations with a common mission, which was to be a voice for the underserved and those who are marginalized in our country. As a consequence of that, we have hospitals located in communities that serve very poor people who have lots of illnesses and issues. We are a hospital-centric company that is trying to move away from that to become much more health-oriented. In order to do that, we need to build the structure and the infrastructure and build out our networks, and then use data to help us be able to manage patients across that network. We have been in the process of doing that now really for 7 or 8 years. We have been steadily moving more towards a value-based business model for ourselves. We have 2.4 million individuals who in attributed lives in some type of value-based arrangement. In some of our communities, we've gone full capitation or hospital capitation, which encourages us to manage outside the hospital walls and to move deeply into social determinants of health to help people maintain their health. Our vision as a system is that we want to have a voice in transforming how healthcare is provided by demonstrating that through what we do. And so we are developing pilots, we're developing home health programs, living quarters, and our whole focus is to manage patients across that entire continuum of care. And that way we will be able to provide value to them by creating a structure that removes the friction from crossing the system, puts them in the right place where they need to be, and then hopefully, over long haul, improve their health. And that will, in fact, have value for their lives, and we will benefit as a system because we'll be incentivized to do that.
So, I mean, that you're touching on we've had some really good conversations on social determinants, and it's a space that we look at closely, but that's really fascinating, the depth that you're going to, which raises a couple of questions, one of which, who pays for that? Vincent, are you going to pay for that? Are you going to be building, buildings and all kinds of things? How does that work from a payer standpoint?
Social determinants of health, just like many other social of conditions that we're facing, are very complex. And we at the Blues, we are 100 million members over, so that's a full 1 in 3 Americans, 1 in 3 Americans. We therefore know that a lot of these solvable problems are local. And we partner with the medical community as well as with our members to try to close those gaps. And so like resource gaps, whether it's healthcare resource gaps, whether it's points of care, we also make an effort to provide transportation to the appropriate resources that patients need. And we have demonstrated gains in those types of programs that we have started.
Vivian, you've spoken to me in the past about your work on your book and the fact that you're studying a number of organizations that are really working to enhance the value that they deliver. And we've heard from a couple of healthcare systems around that now. What are the trends that you are seeing in organizations that are moving toward value and doing a good job of measuring it, but more importantly, delivering it for patients?
Well, thanks, Ben. I want to start by saying that I think it's really admirable how committed we all are to value, and thank you for your leadership, Seema, in guiding us in that direction. I think it's clear that there is a widespread acceptance and actually even energy around moving this country to value, that fee-for-service is really not a sustainable future for us. And one of the reasons why I decided to leave traditional healthcare, not because I didn't want to be ranked by U.S. News & World Report anymore, but it was really because I felt like there was a real role for technology and particularly data to play. And I think that is a big function of U.S. News & World Report. The question is, how do we actually collect data in a way that is usable to every element, every step of the value chain, whether it's health systems like many of us, or probably most importantly really the patients and their families, in a way that enables everyone to assess their value that they're contributing and the value of the suppliers and the people that they are serving. So at the University of Utah, when I was there, we were very focused on quantifying our value to the system. What were our actual patient outcomes at an individual patient and physician level, and what were the costs of care? And for us to drive value, we needed to know that, and we also needed to hold our suppliers accountable for that. In some cases we had data, other cases we didn't, but the more data we had, the more effective we would be. I think the same is true at the patient level, the consumer level. I'd like to just maybe add one layer to this discussion about value in terms of transparency of data. I think there are traditional forms of data that we want for patients to be consumers, like price transparency. I also think to improve people's health, there are insights that they need to have about their own health outside of the healthcare system, recognizing, I think as most of us do, that the vast majority of health is determined by what we as individuals consume, how we sleep, how we exercise, and not what happens in the walls of the clinics or in the hospitals, even though that's where most of our lives are. And so how do we come up with new sources of data to empower patients to actually care for their own health, whether it's continuous glucose monitors to measure their sugar or Fitbit exercise, whatever. How do we collect new sources of data and make those also available and actionable to patients? I think should be a really important part of our discussion.
Mm-hmm. And Rachel, you spent a good portion of your career studying variations in care and in quality and in value. What are the insights that you have from that research that could help us understand how to measure value? We've heard how individual organizations are thinking about it, but I think from the perspective of U.S. News, defining it in a manner that can be consumed by the public, and certainly, obviously, with CMS, there's a scientific challenge in creating value measures that are meaningful and that can drive increases in value.
So I think that, first of all, recognizing that there's substantial variation in quality of care across providers and in value of care is key to trying to address that variation. And I think that we've come a really long way in the past decade or two in starting to measure that variation in quality and variation in value and move towards payment systems and other types of systems to try and address those quality variations. Value now is routinely tied to payment, which I think is definitely a step in the right direction. Our fee-for-service payment system, I think we would probably all agree, is broken. We don't want a system where we're paying more for higher intensity care than we would rather pay more for high value care. I think the challenge with doing that is that healthcare is not a regular competitive market. It's not. It doesn't respond to incentives in the same way that other types of industries might. And part of that is that when we start measuring value of care and we start tying incentives to it, there are providers who do much worse under those systems, and those providers often tend to be those that take care of a disproportionate share of vulnerable populations. And so one of the things that I've learned over the years of studying variations in quality is that simply tying payment to value may not help improve quality of care for everybody. It may actually reduce access to care and reduce quality of care for some of the populations in this country. And sometimes those are the most vulnerable patients who need our help the most. And so I think that it leaves us a lot of room to think more critically about how to measure value and not take a one-size-fits-all approach to trying to improve value across providers.
And Vincent, you've got health relationships between your health plans and providers across the country. How do you see that idea that Rachel just articulated playing out in terms of the localization, the local definitions of value that need to be tailored to the population and also to the providers and those who are paying for care?
Yes, that was very well said. Because once you run the statistics and you have the data, you have to apply those value principles to what the local market has in terms of resources. And we at the Blues do a good job at partnering with our provider groups. We have over 31% of our payments now to value-based programs that have about 75 million members in them and over 300 groups of physicians and providers to provide that health care. And what we find is that it's really nuanced. It's based on your locale, it's based on your providers, it's based on your social determinants, whether or not you can get to those visits. And so we have to be careful that there's really no panacea, I feel, of a solution being a practitioner. Just like value-based is not the only thing that should be a factor. I can be the greatest physician in the world and treat one patient, and maybe that solved their problem, but I need to treat patients. So there has to be a volume piece to value. And that's what you have to look at from a practical standpoint when you're engaged with the healthcare system.
Mm-hmm. Mm-hmm. So, to the point that sort of the volume matters here, things add up fast in healthcare, right? We heard about the budget that you oversee, and there was a study recently in JAMA looking at waste in healthcare, right? And it estimated that as much as $100 billion per year is wasted in low value or inappropriate care. And so I wonder, both from the CMS standpoint and from your organization's standpoint, how do we remove that low value care? How can payment reforms work, both at CMS and in other payer relationships? And how can an organization like US News contribute to removing that form of waste from the system?
I'll take a stab at it. So I think a couple things. I mean, one, we're looking for lots of opportunities to get rid of unnecessary costs in the system and moving towards, a system that's paying for value. I think to the extent that we get it right in terms of how we pay for value, and I think you brought up some great points, which is, it's not that simple to say we're going to pay for performance, because performance is going to vary by things that maybe the provider cannot control, which are things like the socioeconomic status of their patient that may influence their health. So, but we can work on that and we can tweak that. So you've got the value piece of it. The other part of the whole equation is when you are paying for value, then that naturally creates incentives for providers to not deliver care that is not that is high cost and isn't going to improve quality. So I think it's about setting the incentives in the appropriate place so that you're paying for performance. That being said, I think there's also a whole other piece to the transition to value. We have to understand that there's a lot of things that stand in the way of providers moving to value. I think the data is really important. Providers need patient data as well, and they don't always have that. That's something that we're trying to change at CMS to make sure that providers have that complete history on their patients. That's why efforts around interoperability and making sure that patients have access to their data, but that the data can follow them as they move throughout the system. That's also going to contribute towards reducing waste. One of CMS's top initiatives is something called Patients Over Paperwork, and it's all about making sure doctors are spending time with their patients and getting rid of all the unnecessary regulations that stand in the way of value. One of the things that we're working on is the Stark regulations, and Stark is a law that's been on the books for a long time, and it's about making sure that providers aren't sending patients to their friends and their family where they're going to get some kickbacks around utilization, and but that actually stands in the way towards value-based care. And so those are the things that the agency's taking on, right? Trying to get rid of burdensome regulations that stand in the way of value, and trying to promote things like interoperability that will help the system move towards value.
And as a follow-up to your comment about creating the right incentives, I'd be very interested in hearing from from the position of the provider organizations that you represent. What are the incentives that are working against value for your organizations today? What can payers like CMS and the Blues change to help you on that journey?
Well, frankly, we applaud at Intermountain Healthcare, we applaud the moves that CMS is making towards value. In fact, at Intermountain, 50% of our top line revenue comes from full value-based payments. And a couple of years ago, maybe the most important strategic conversation we had as an organization was, how are we oriented around the care delivery around that value? Because essentially we're in two different business models. One business model is providing the safest, highest quality, cost-effective care we can when people need our services in our acute facilities. The other business model is how do we work longitudinally to keep people from needing our care in our facilities. And we all know that medicine is practiced on the margins, that it's always easy to do more. And frankly, as a state senator prior to joining Intermountain Healthcare, I oversaw the Utah Medicaid budget. And when I took office in 2009, it was 18% of our general fund spending, but by 2020 was projected to grow to 36%. And the alternatives were pretty stark. If we stayed on fee-for-service, we would cut rates and question everything that the providers did, or we could move to a new model. So we unanimously passed in 2011 legislation to cap Medicaid spending to the growth rate of the state general fund, but then capitate that spending to our providers with one important caveat. We decided that on top of looking at claims, we would look at incentive providers to payers towards the medical expense trend. Because what happens over time is you start engaging with a Medicaid patient to keep them out of the hospital, get them into a primary care setting, and traditional capitation would look at the claims and they would say, well, that patient wasn't that sick. And we just agreed as a state that we would, any incentive payments that made it to providers would count towards medical expense trend. And so we've been able to grow around 2.5% to 3.5% on Medicaid in a very stable Medicaid environment as the health systems like Intermountain Healthcare, who I subsequently joined, have been working to reorient the delivery system around keeping people out of our hospitals. That's when we say on the rankings for U.S. News & World Report, the investments that we're making, we essentially broke our hospital system in two. We created a specialty-based care group. We felt like we were really too much oriented around hospital services and separated our clinics into a community-based care group. Our community-based care group takes all of our top-line dollar risk, and their job is to keep people well and out of our hospitals while we manage cost per case on our hospital side. The reason why we think that's so important is that is allowing us to innovate with hospital at home, with telemedicine programs, with migrating business out of the hospitals into lower cost settings. And that's frankly where we think the innovation should be. Not on the latest, greatest, really expensive surgical device in an inpatient facility, but maybe on a really low-tech way to monitor people in their homes so that we can transform our hospitals maybe just into ICUs while allowing technology to allow people to stay in their homes and stay healthier. So that's the transformation we're interested in, is where does healthcare need to be sustainable societally? And the more risk we want at Intermountain Healthcare to take full clinical and financial accountability for the people we serve. And in so doing, believe that with all the new advances in technology, that the name of the game is keeping people well longitudinally and taking responsibility for that. There is no way, in my mind, in our minds at Intermountain Healthcare, the system can transform by external pressures. It's got to come from an alignment of incentives and a reorientation of what we decide healthcare should be.
So that opens up a question that I want to ask Marvin. We got your thoughts on that, Dan, and then I would like everyone else to respond to that. But it's the notion of measuring community health or measuring population health. You have a set population you're talking about there. How did they do over the last 5 years, right? Can we measure that, taking into account socioeconomic status? I get that, but Ben, we take account socioeconomic status already. I don't think that's a problem as correcting for SES, right? But can you define a population that you're responsible for as a health system, and then can you measure progress or lack of progress within that? Is that, I mean, that's something we have talked about internally at US News. Is there something to that? Does that make sense as a way of evaluating a health system and a community? Marvin, what?
Well, I think that it does make sense, but it's incredibly difficult when you don't have enrolled patients. And so the lives that are attributed to us, for the most part, are people that we don't know exactly who they are. Now, the patients who are capped, we know who they are. And with that population, we can track that population over time. So we will know if we're managing their hypertension. We will know if, in fact, we're able to keep their diabetes under control. For the other groups, it's more statistical analysis to be able to see what type of impact we're having on the broader population and then infer that to the population. But until we get to a circumstance where we have information on who those patients are so we can target them early and get to them early and then manage them early, it's incredibly difficult because you just don't know who they are. But it is a worthy goal that we should have, and we certainly have that goal inside of our own organization, is to improve the health of a community that we're serving. And we've gone out into the community and developed programs connecting all of the services that are available in the community. So if you come to one of our emergency rooms, and you're poor, disenfranchised, and you've got a lot of issues, and we know we can't solve all those issues for you in the emergency room, we can make a referral from our emergency room into a community service. And then we can track that, what happens to you over time. Did you make the appointment? What was the result of the appointment, et cetera, et cetera. So when the patient comes back, or if they come back to the emergency room again, we've got all that information. And then we can see what type of impact we've had on that patient's life.
Yeah. Vivian, is that measurable?
You know, I think it's a really interesting idea from a perspective of U.S. News in terms of holding a community responsible for the health of their population. It may be difficult for each individual system to demarcate exactly which patients they are specifically responsible for, but there's no question that in every community there are a number of systems and they are responsible for the health of that population. And for an external entity to come in and say, hey, okay, how are you guys doing as a community of health systems? In some cases, how are you working together? That's a kind of a radical idea in some communities, to actually improve the health of that population. I think that could be a very powerful driving force that would be very, very useful. I do also want to say that I think that in this drive to value, I would love us to talk just briefly about, or maybe a little bit more about quality. I think that the issues that were raised around risk adjustment, are we really crediting people with the right kind, crediting with the level of quality work that they're doing given the complexity of the patients is a really reasonable concern, although there are risk adjustment algorithms that can continue to be refined and improved, and especially in this era of big data, I think there are even greater opportunities there. I also feel like we're often missing in this narrative the role of the physician and clinician, specifically empowering them to drive more value and more quality rather than burdening them with 972, whatever the new number is, of quality metrics that mostly feel out of their control. And in that respect, I think many of the measurements that we have on data are not at the right level. I think at a hospital system level, when we were ranked, every physician thinks that they're above average. So that's somebody else that's causing the 2 stars, not me. And so I think that we should think a little bit about how do we provide data in a way that's not punitive, that's not embarrassing, that's not going to be something that I'm going to reject as a clinician, but enables me to learn and improve. And if we could shift the narrative of how we think about quality to that, to actually enabling people to improve and learn and get better, I think we would make a lot more progress, which we need.
Rachel, talk to the notion of community health, measuring community health. Is that a viable concept?
So I think it's a great idea. I think that what we know about health of people is that it's created in large parts by the communities that they live in. And so holding health systems or holding communities responsible for the health of the people that live there, I think is really ultimately the goal we want to get to. I think it's complicated to do that in some markets. There are some markets that are very competitive and have a lot of different health systems, so attributing patients to a specific one is difficult, though it may have the positive benefit of making systems work together to try and improve the health of the population as a whole. I think it also has the benefit, which is hard to get to any other way, which is that social determinants of health, such as housing and employment and access to food, we need to invest in those if we want to improve the health of our communities. And if we're going to hold health systems responsible for the health of communities, it really gives a stronger incentive to start meaningfully investing in improving those types of determinants of health. And so I think that would be valuable, but it's challenging. It's not a turnkey solution, but I think is one worth striving for.
You know, it's interesting that you talk about investing in communities because, of course, most hospitals are tax exempt and have an obligation to invest in their communities. And I wonder if you could speak, and I think you had some thoughts, Seema, on this already, to the role of nonprofit health systems in providing that community benefit and what you see as the obligations of health systems to invest.
Well, they shouldn't be suing patients when they can't pay if they're not for profit and they're not posting their charges online and people don't know what they're paying for. So I'll leave that one alone for a second. But let me go back to the point that we're sort of bringing up as we talk about quality. I think it sounds great. Of course, we want to pay for quality and we want to pay for performance. One of the things that happened when I came to the agency was we did a national listening tour. We went out to the front lines, we talked to providers, we talked to nurses, doctors, hospital systems. And one of the things that we heard about was the burden of measurement. You know, across the board, of course we believe in quality, but then everybody has a quality measure. Let's measure population health and let's measure smoking, and every group has their quality measure that they want to have out there. And the issue became really real to me when I visited a hospital, and I think it was in Cleveland, Ohio, and they took us down to the basement, and in the bowels of the basement they had 16, 17, 18 people, clinicians, and that was their job, was to work on reporting measures. And when I saw that, I thought, we've gone too far with this, right? I mean, now we're spending all of this money to report measures. And so quality is important. We should absolutely be paying for value and performance, but we have to make sure that the measures that we are reporting are the right ones. You know, I think looking for measures that I call them my one-shot wonders. You can look at one measure that measures not only quality, but cost and efficiency by that single thing. Unfortunately, a lot of the measures that we have in the system are process measures. You know, at CMS in the first couple of years, we've already kicked out about 25% of our measures because they were processed. There were things like, did the doctor perform a physical and a history, you know, the patient? I mean, those are not quality measures, those are process. So I think that in this discussion, we have to be mindful of what we're measuring and how we are measuring it. To the extent that we can get measurements directly from the medical record or from claims information so that they can be done on the back end, I think those are great. It's a great idea because the physician's not having to go to a lot of extra effort. But to the extent that we're requiring, you know, manual entry, we have to be careful of that until the system can keep up with the request, right? So until the system can actually provide this data in an easy way, I think we should be careful about not burdening the system with unnecessary measures that don't really work for doctors and don't work for patients.
Vincent, does your claims data allow you to make these kinds of evaluations, privately?
Well, yes. Well, before I get to that, I think what was said by Vivian and some of the other panel members is very significant. I think what they're hearkening back to is a co-production model of delivering value-based care. So you involve all the stakeholders into the development of what is quality and how to deliver quality. We've done that. You know, we're in every zip code, and what we find is that you need to put the patient at the center, and you need to coordinate with the providers to deliver that quality care, and that quality care will look differently depending on where you are. And so we have shared decision-making, shared risk models with provider groups, whether it's in North Carolina with our Premier program or our PCMH program in South Carolina. We've shown meaningful cost reductions as well as quality gains, and that which we're very proud of. We do have lots of data. We have data that we de-identify, and we use those, and we use this data to first, we want to define, so what are the disease states that are the most concerning? And then we also use data to find out what are the treatments. As was alluded to, technology is good, but it's not always the answer. So you want to have both treatments that are fit for purpose, and then you also want to have quality metrics that are fit for purpose, like Seema's hinting to too. We don't want to be too measured so that providers lose interest and they feel like they're being put upon. And so we use our data to effectuate change, both with patients' behavior and with the way the provider groups treat those patients so that we deliver quality.
And does that data allow you to evaluate, internally, again, health systems or individual hospitals? Can you say these guys are high performing, these guys aren't?
Well, as was stated, that's a complex way to look at things, and also maybe not fair, because quality can mean different things. We believe that quality means, did the patient benefit? Does he or she think that they are better now than they were prior to engaging with the system? And so, as was stated, that can be very comprehensive in nature, whether it's closing their social determinant of health gaps, getting them on programs that help them lead healthier lives, or getting them the new generation technology treatment plans that they need.
Mm-hmm. Okay.
Marvin, how can incentives be better aligned for your diverse set of health systems and hospitals? When what can payers do, and what can your partners in the community do to create that sort of community of value?
Well, the system in and of itself historically has had a bit of an adversarial nature to it, of course, because it's a bit siloed. It's not one industry, but it's sort of multiple industries thrown together, each with a sort of incentive or a profit motive, if you will, whether they're built into it in order to sustain your organization. And so you have to really make the effort if you want to collaborate around a common set of incentives. Now, what we've done over time is try to move out of the adversarial nature of rate negotiations and move into more of a collaborative mode built around what is best for the patient and the patient population that we're serving. And we have long-standing relationships with a number of insurers throughout the West, and now, of course, developing them throughout the country, where we have worked together for the common good, which is to decrease overall costs and improve the outcomes. But you have to make that effort to get there. We're involved right now with Blue Cross and Blue Shield of Arizona and Blue Cross of California, and a company called ODA, who's in a pilot in both of those states designed around removing the friction from the billing system. So the idea is that the payer, the providers will work together in a system that makes purchasing health care for the patient no more difficult than going to the grocery store. To just remove all those friction points, the bills they get, and et cetera, just take that completely out. And the insurance companies, the payers, will take on the burden of managing all of that, making sure that the providers get paid in a timely manner, much quicker than we get paid now, that the bill that the patient gets is much more simplistic and understandable and comes not 60 or 80 days after they've been in the hospital, but really very shortly after they get in the hospital. And so that took a trust factor, if you will, between us, and we have a history of that, which is probably why they came to us, to say, okay, we're gonna do this together, and we're gonna share information, we're gonna share data to help make a better decision and a better outcome for the patients. And that's sort of our history, but it takes, again, you have to make the effort to do it. And you have to, if you move away from the fee-for-service sort of structure and say, we are indeed moving into a new world, how do we reinvent ourselves in order to be able to compete and to produce the best value for the patients, because that's really ultimately what we're supposed to be here to do. I would like to go back and comment on the issue of how many measures we have and quality and variation. There's no question there's a lot of that out there. And I mean, there's thousands of measures. And you're right, physicians get frustrated with this stuff very quickly. What we've done as a system is said, there are three things we want to get right. We want to get sepsis right, we want to get C. difficile right, and we want to manage hypertension. And if we do those things, we know that that will have a positive impact on all those other measures. Because if you get sepsis right, it affects the entire hospital. So if we can catch those patients early, get them the fluids, get all the stuff that they need, the other measures, in a sense, will take care of themselves because the overall system is working a lot better. And as a large system, to the issue of variance, we're now in a position to say, here's our sepsis bundle that we got from our data lake, from all the information that we have on how we treat patients, and we spread that to all 142 hospitals. Every emergency room has it embedded in the EHR, and we have some cases we have sepsis navigators who are out looking for patients who have these issues. And so we can take the variance out, we can save lives, we can decrease costs, and we can improve quality just by managing those three components.
So, Rachel, we've heard Marvin describe three sort of magic measures that really work in all contexts. We've heard Seema talk about the need to remove the measures that aren't really sending signal and are burdening providers. what are the, if you had one or two measures that you would like us all to focus on, can you tell us, notwithstanding the local needs of different populations, are there things that we can look at universally that matter in all contexts?
Well, I think one thing that we don't measure effectively now that would be very helpful, I don't know that it's like a magic bullet, but it's important to individual patients, is patient experience of care. And not just patient experience of care, but whether or not we are delivering care or achieving goals that are concordant with patient goals. And so a lot of our quality measures, again, are sort of a one-size-fits-all metric. But a patient with heart failure who's 45 and has mental health conditions is very different than a patient who's 90 and has heart failure also. And the goals of those patients might be very different. And the way that we might optimally deliver care for those patients would be very different. And so I think that if there were a way to achieve the goal of making sure that patients were getting care that was concordant with their goals, that would really help ensure that we were delivering high value and high quality care to people.
Mm-hmm. So I think we're going to get to the last word here, which everyone gets. I get the last word, but before we get there, let's just go in sequence here. Dan, we'll start with you. What's next? What's the next most important thing we need to be doing here?
Look, as we've looked at it through our patient's eyes, that's how we're trying to reorient our health system. And frankly, the value equation for a patient is health over affordability. And as our Office of Patient Experience and our Consumer Experience, we're trying to figure out exactly how to help meet people where they are and meet their expectations. Our mission as an organization is to help people live the healthiest life possible. And the measurement has got to flex based on where they are in their journey. And that requires a lot of engagement and really attacking the experience of gaps that have arisen around a payment-driven, transactionally driven system. We think the systems of the future will, again, want to take full accountability, both clinically and financially, for that journey, hopefully longitudinally. So the investments we're making are investments to actually meet patients where they are, to understand what they need, and to hopefully do that in a seamless, transparent way to simplify this entire process. Previously, as an industry, we've given people a laminated insurance card when everything was on the line and said, good luck, go figure out what you need. And frankly, those asymmetries of information, which we all know about acutely internally, are an opaque mess for everybody else. And our goal at Intermountain Healthcare is to simplify that process, and to do so by aligning the incentives and being willing to accept the responsibility. And we intend to do that.
Good. Seema?
I think the word is the alignment, and it's not just across providers and payers, but also having patients as part of that equation as well. So making sure that they have incentives to seek value, and that's why they have to have information on price and quality, have to have their medical records so they can move around the system. And for providers is we need to put out more value-based models so that we can pay providers differently. That's something that CMS is very focused on. We've been putting out models. And as part of that, we've got to make sure we get the measurement right. The other thing that we haven't talked a whole lot about is the adoption strategy, is how do we encourage more providers to participate in value-based models. So we have to figure out what we need to do to support them through better data, through alignment with payers. I don't think it works well for the system that there's so many different models. It's confusing and it's difficult, and it adds to the complexity of the work for providers when they're dealing with multiple sets of measurements and multiple models. So I think the alignment across the system and better coordination around payers. And then finally, we need to continue working on those things that are thwarting innovation in the system. We need to make sure that we're supporting innovation. I think government has a very important role to play here, that we're not just paying for what people do, but what they produce at every level, whether it's our contractors, whether it's our providers, whether it's states and Medicaid programs, that we're setting out the parameters. We're saying these are the outcomes that we want you to achieve, and government's staying out of the way of micromanaging the process.
Rachel, what's next? Your book is next, right? You're gonna put all this together and explain it concisely.
I'll let you know when it's done. So I think that my goal for for the health system, if we could achieve it, would be to have high quality care across all providers and have it be equitable care across all providers. I think our ability to get there in part depends on allowing individual providers to tell us what they need to do to provide high quality care or high value care, and in understanding that a one size fits all solution is not going to get us there. I think that if we are committed to having a high value health system, it needs to be an equitable health system in which we acknowledge that there are some institutions and some providers that we don't want to fail, and that we're going to have to help them succeed, and that there are other providers who can actually help in that goal of making sure everybody succeeds.
Okay. Marvin?
Well, you know, we're on this journey from sort of the traditional structure to this new value-based structure. But still, as we sit here today, we're still in both worlds, which is incredibly difficult to navigate and to know where the incentives are and what you're supposed to do in any given geography. And for me, it would be, let's build more incentives in the system so we can pick up the pace. The more clarity that we have, for our providers and for our system leaders in terms of where the ultimate goal is, the better. And right now, things are still pretty muddied in terms of where we're going and what's exactly happening. And for the most part, value-based structures are still probably less than 30% of any given system's revenues, which means it's not enough yet to really get their attention and make them have the switch go completely over. So I'd like to see us sort of pick up the pace a little bit. I agree that hospitals are going to become, for the most part, large intensive care units, and most other services are going to be external. And the quicker that we can get the incentives in place to encourage that, I think the better.
Good. Okay, Vincent?
Yes, so we at Blue Cross, we are partnered with 90% of providers in the country. We're in every zip code, and we cover 1 in 3 Americans. We are using those strong local partnerships to really move us to this value-based world that we are groping towards, as has been stated. That is coming with it some growing pains. But we feel that we are uniquely placed to support this transition so that all Americans get the proper care that they need.
Good, thanks.
Second to last word?
Second to last word, yep.
So I guess I will just double down and echo a little bit of the words of Seema and also Marvin. I think if we're going to do value, let's just do it. I think it's really almost impossible to live in both worlds. They're 180 degrees opposed. I also feel like the goal should be primarily health. And I know we have two sides of the equation, but health is really the most important thing. And if we focused on health, we'd talk a lot more about prevention. We'd talk a lot more about the integration of mental and physical health. And we'd be focusing on what's important to most people, as opposed to getting caught up in a lot of our administrative talk. And then lastly, I guess I'd say that we really need tools. We need to build more tools to make this transformation happen. As Vince says, it's not easy for us to completely reprogram all of our systems, and the more we can go maybe even outside of traditional healthcare for partners to help build those tools, I think the better off we're going to be.
Well, the last word is wow. I thought that was fantastic. I really appreciate the insights, the candor. I mean, you know, we couldn't ask for 6 better people, and Ben, to sort through this. It opens my eyes about some of the complexities, but also some of the promise here, and we're going to keep at it. And we look forward to getting back with all of you guys as this develops. And it's a good ongoing conversation. I hope you all found it as insightful as I did. Thank our guests.